Noon. Delegate Rodney Willett, your chair for the Subcommittee for Health and Human Resources. We're delighted to have you here this afternoon, and we will take attendance. And we've got a quorum. I wanted to make just a brief announcement at the beginning. I know we've got a lot of folks in the audience. We actually have some folks online as well. All of the bills, 100% of the bills we're hearing today have been heard before. They were heard in the corresponding committees and then reported to us. So I make that point to say that we have had hearing, we've had public testimony on those. We even have some written testimony on those. Today we are solely focused on the appropriation side, the money side of the equation, so we will not take additional testimony. I just wanted to flag that. With that, I'm going to jump right into our agenda. First up, we have HB 1245, and the patron has asked us to strike that bill.
So moved.
Second.
We have a motion that's been properly seconded to strike HB 1245, and that will go on the board. Okay, and by a vote of 7-0, we have struck HB 1245. Next up, we have HB 66 from.
You can handle that if you need to, too.
Yeah.
If he's not here, I don't think he's coming.
Okay.
He had notified us.
Yeah, Amy, if you will defer to staff on that one. Delegate Fagan's bill.
Sure, Mr. Chairman. HB 66 by Delegate Fagans directs DSS and DMAS to contract with a vendor to study the modernization of the IT systems used to administer our federal benefit programs. DSS and DMAS will then submit a legislative report based on those findings by December 1st of this year, and will move forward with that plan. DSS will need about $318,000 general fund the first year and $182,000 non-general fund to contract with the vendor.
Mr. Chairman, I move to report.
We have a motion that's been properly seconded to report HB 66. Go on the board. And that reports by HB 66 reports by a vote of 7-0. Next up, HB 267, and we've got a recommendation there to pass this by for the day.
So moved.
Second. We have a motion that's been properly seconded to pass by for the day HB 267. All in favor say aye.
Aye.
Any opposed? HB 267 is passed by for the day. Next up, we have HB 335 from Delegate Anthony. Yeah, that'd be great.
Mr. Chairman, members of the subcommittee, this would establish an independent pharmacy access and resilience pilot program in the health department with an expiration date of July 1, 2030. I think most of you have heard about this bill. It is contingent upon funding. There is a budgetary impact of $65,000 to set it up, and then an ongoing of $275,000 almost to $300,000 in 2028. Health Department has not been able to identify any non-general fund source, so it would just be dependent on general fund dollars.
Mr. Chairman,
Yes.
I have a motion to gently lay this on the table.
Second.
We have a motion that's been properly seconded to gently lay on the table HB 335.
With an expiration date of July 1, 2030. I think most of you have heard about this bill. It is contingent upon funding. There is a budgetary impact of $65,000 to set it up, and then an ongoing of $275,000 almost to $300,000 in 2020.
Okay, there we go.
Delayed, huh?
Susan Masser never fails to impress me. She was talking ventriloquist. That was amazing. Okay, thank you. Next up, we're going to go to HB 470, Delegate Cohen's bill. Delegate Cohen, we can summarize this for you, if that's okay. You want to do that one?
Okay, this one was heard in HHS, and that directs the medical DMAS to modify the program rules for consumer-directed services that are available through certain waivers. It would allow an individual receiving services to act as the employer of record for his or her own service delivery and designate another person to perform all or part of the duties of the employer of record on their behalf. when they're unable to perform such duties or direct their own care. There's some details related to how that happens, and it provides the department with the authority to limit the amendments to specify that the individual could only make these changes about twice per calendar year, evidently.
Second.
We have a motion that's been properly seconded to report HB 470. We'll go on the board. And by a vote of 6-0, HB 470 reports. Delegate Cohen, thank you so much. And next we have HB 483 from Delegate Delaney.
Mr. Chairman, members of the subcommittee, you've seen this bill before. We had it last year. It was passed by the General Assembly. And so I won't go into it unless there are any specific questions.
Mr. Chairman, move to report.
We have a motion that's been properly seconded to report HB 483. We'll go on the board. And by a vote of 6-1, HB 483 will report. And in the home stretch here, we have HB 794, and I believe we have a substitute.
Move the substitute.
We have a motion that's been properly seconded to move the substitute. All in favor say aye.
Aye.
Any opposed? No substitute is before us.
Mr. Chairman, this is just directs the Department of Health to develop a strategic plan for opioid response to reduce the rate of drug overdose and drug overdose deaths in the Commonwealth. It's a recommendation by the Joint Commission on Healthcare and has a one-time cost of $150,000 that would be funded through the Commonwealth Opioid and Remediation Fund.
Okay.
That's substitute.
We have a motion that's been properly seconded to report with substitute HB 794, and we'll go on the board. And HB 794 reports by a vote of 7-0. We next have HB 23 from Delegate Carr, our Vice Chair. And do you want to cover that?
Okay.
She's on a roll.
Mr. Chairman, this is a bill that's been before the body before. It would direct the Department of Medical Assistance Services to seek all the necessary federal approvals to allow for the community living and family and individual supports developmentally disabled waivers, just those two specific waivers to provide compensation for a direct support professional to be in the acute care hospital under certain circumstances and be reimbursed for that. There's a cost of about $769,000 and some change, general fund with some non-general fund match in 2027, and a cost of $1.65 million general fund with non-general fund match in 2028.
Okay. Yes, thank you, Delegate Creeley.
Sorry. Mr. Chairman, I would move to table this bill gently.
We have a motion that's been properly seconded to lay on the table HB 823. And go on the board. And by a vote of 7-0, HB 823 is gently laid on the table. Next up, we have HB 1284, and we also have a substitute for that bill.
No, Mr.
Second.
Chairman, that substitute came up from HHS.
Oh, we did come up. I apologize. Nope, I'm
No
not reading
substitute.
fast enough. Strike what I said. So we do have HB
Withdraw.
1284 before us.
Mr. Chairman, that one would direct DMAS to modify state plan provisions covering provider consultation. The substitute essentially does a rewording to make sure that those consultations are through the defined code requirements for telemedicine. The substitute does not have a fiscal impact.
Okay. We have a motion that's been properly seconded to report HB 1284. Sorry. On the board. And by a vote of 7-0, HB 1284 will report. And last but not least, we have HB 1357. This one does have a substitute.
Yes,
from us.
Mr. Chairman, there is a substitute on this one.
We have a motion that's been properly seconded to report the substitute. Move the substitute. All in favor say aye.
Aye.
Any opposed? The substitute is before us.
Mr. Chairman, the substitute directs the Department of for Aging and Rehabilitative Services to convene a work group of stakeholders for the purposes of conducting a comprehensive study of the quality of care, resident safety, and operational practices of nursing facilities in the Commonwealth. The substitute would direct the department to submit the findings and recommendations to 3 additional groups. It would be the governor, the chairs of House Appropriations and Senate Finance Committee and Appropriations, and then the joint sub for HHR oversight. And it moves the date for when this study findings and recommendations would be due to September 15th, 2027. That gives them ample time to complete the study.
I just want to make a quick comment on this. It's taking a very important bill, but making it better, and I really appreciate staff for jumping on a couple items which Susan just described, including the date, just to make that a more realistic date to meet. Thank you. And with that, we'll entertain a motion.
Move to report the substitute. Second.
We have a motion that's been properly seconded to report with substitute HB 1357, and we'll go on the board. And by a vote of 7-0, HB 1357 reports with substitute. And that concludes the bills we have. But wait, there's more. We have two presentations for us today. And I was checking with Susan. We're going to start out with Carl Ayers, who's here with us from Social Services. Appreciate you coming back. And podium's yours. Come on up.
Good afternoon, Mr. Chairman, members of the committee. Pleasure to be with you on Friday afternoon as Jeff and I get to close out your week on a series of presentations that we'll walk you through this afternoon. We're going to talk through the child welfare and SNAP changes that are in front of this committee. The SNAP you've heard a lot about, the child welfare not quite so much, so I'm going to start with that piece of it. And as always, feel free if any of these raise questions to let me know as I move through these from that end of it. Over the past year, we did a deep study into the safety side of our Child Protective Services system across the Commonwealth of Virginia. We really focused on 6 major pillars as part of that work effort. And you will see those 6 pillars here, one being our local workforce, one being the Child Protective Services system in and of itself, permanency, which is when children get into the foster care side of it, the connection with behavioral health, as that is the major driver of children and families that end up in the child welfare system, any prevention efforts that we can do beforehand so that families do not end up in crisis, and that is all underpinned with how Virginia's system works in the modernization of our oversight and infrastructure, otherwise known as a state-supervised, locally administered system. So under those six pillars, we did a year-long study in partnership with McKinsey and Company to help us work through that. On this slide, I will not go through all of this with you this afternoon, but there were 25 recommendations that came out of that. In the Governor Youngkin's outgoing budget, he prioritized 4 of those. So I'm really going to focus the conversation this afternoon on those 4 primary areas. 3 of those require legislation. 1 of those is just a budget amendment. So I'll walk you through that this afternoon. What got a ton of the attention through that study was the number of calls that come into local departments of social services and our Child Protective Services hotline, and how the decisions are made in regards to those calls that come in. If you look over across this chart, what you will see is year over year the number of calls that come in alleging children are abused and neglected, and the number of calls that are screened in, which is the bottom side of that. The screened in piece are those that actually receive a response according to the Code of Virginia. What you will see is a significant increase in the number of calls that are coming in, but not a corresponding increase in the number of calls that are being responded to. And so we were asked to really kind of dig into that and take a look at it and see how does that screening process function and what does that look like. As part of this work, we did a comparison to 27 other states. All 27 aren't on here, but we compared ourselves to other systems that are set up like Virginia and the national average. So this really complicated chart, basically what you will see is that in Virginia, we screen out about 60% of all the calls that come in alleging child abuse and neglect. The national average is 43%. So just how you compare ourselves with other states. And if you look at the average for other state administered states, we're at 63, they're at 63%. So in locally administered systems, they tend to screen out more calls than you do from a state centralized system. That's important as we get into the recommendations. The majority of the referrals come directly to the local departments of social services. So 60% of all referrals come directly to the 120 local departments. At the state, we receive about 40% of the other calls. So 60% local, the other 40% we already take at the state hotline. So I run a 24/7, 365 hotline. And we also have a mandated reporter portal where an individual that's a mandated reporter can actually go in and submit their concern online. You will see how the screening rates vary significantly depending on how that call comes in. If you call a local department, they're much more likely to screen the case in. If we take it at the hotline or through the mandated reporter portal, they are much more likely to actually screen that case out. Then as you look across the rates, and this is where it really got into the inconsistency from jurisdiction to jurisdiction and region to region. We have 120 local departments. I'm not going to throw that on the slide for you. So what we did is region by region. So you will see region by region how significantly the screening process varies depending on which region you're in. That 57% that you look at as the screen in rate. The western region, which is the far southwest part of the state for us, screens in above that average. All the other regions across the state screen in significantly below that average. And so same policy, same tools, same procedures, but they are handled very significantly differently depending on which jurisdiction you work with. That was an important point for the families that were part of the stakeholder group. The families and the providers that worked with us said that inconsistency from jurisdiction to jurisdiction impacts them depending on which department that they're working with. So when you're looking at improving the system, how do we address that inconsistency and try to move forward through that? This piece of it, unfortunately, we do have a number of fatalities that occur across Virginia due to abuse and neglect every year. I'm not going to spend too much time on this, but it's really important to see that we have a number of children that die every year directly due to abuse and neglect. And you will see that primarily they are under the age of 3. 81% of all the children that die due to abuse and neglect is under the age of 3. I could spend more time on this, but it's a really hard slide for people that don't deal with this every day, just the number of children that we have that are killed every year due to abuse and neglect, and how do we prevent that and change that number. What this slide will show you is the prior involvement with our system. So, and what you really take away from this is, are there missed opportunities that we could have protected those children before they ended up in a fatality situation? That's what you really take from this. Take a look at it and see what were those missed opportunities, where could our system potentially perform better. When you look at those fatalities, 23% of our fatality investigations in the past year had an invalid report. That means somebody called in a concern and it was screened out. Nobody went out and responded to them. 76% of those referrals had at least one prior screen out with a reason that it did not meet our abuse and neglect definition. And I'll keep going. I don't want to keep going through these, but what the data tells us is we need to look differently on how we handle those calls that come in to us as a state. And so in those 4 proposals that are included in front of you for your consideration this year, is one of them is to create a centralized child protective services intake system that then actually screens those calls whenever they come in. Right now, with our bifurcated system, all 120 local departments screen those calls differently, depending on their individual processes, depending on how they handle those situations. So the largest recommendation that came out said, We need to centralize that intake and screen all those calls come in consistently so that we are getting a consistent response across our 120 local departments of social services. This would be a big shift for us as you look at how this would function. It's a significant difference from how it works now to what it would look like into the future from that end of it, and it's a significant cost as you look at standing that up. You're looking at this is estimated to take almost 200 staff for us to set this up, get it up and running, and be able to take on this function. So when you're considering that, this is a huge lift to be able to make this shift and be able to do that. The second piece of this conversation, there we go. The second piece of this conversation is, what do we do about those children that are really getting harmed that are under the age of 3? When you look at those screening calls that come in, 55.6% of all referrals for children under the age of 3 are screened out now. 86% of those children are seen timely. So whenever they are screened in, we get out and see them. 86%, 95% is the standard. So we're under the standard. And then only 57.6% of them have an initial safety assessment within the 24 hours of the initial contact. That is a significant workload issue for our local departments of social services. Taking you back to why is centralized intake one of the primary recommendation, is that it is a way to take work off of our local departments of social services that just have more than they can handle and be able to do it centrally. We can't respond to families centrally. We can't go out and provide services centrally, but we can certainly take that function in and be able to allow capacity to get out and see our children and families more expeditiously. So the second proposal that's included in here is increasing the 24-hour response time frame from 0 to 2 to 0 to 3. And that will line up with the data that I just showed you. So that 81% of children that end up in those fatalities, 0 to 3 is where we should be targeting our system. So this changes that. When we did this in 2017, we initially started 0 to 3. Then it was agreed during that process that we would drop it to 0 to 2. The research hasn't changed in the last nearly decade. It's still 0 to 3 that are most at risk. And so this just helps to prioritize our system and make sure we're getting out and seeing children and families timely. The third piece of this is the ability of the state in a state-administered, state-supervised, locally administered system to be able to actually set standards and performance standards for local departments of social services and hold them accountable. For right now, in 2018, as a follow-up to the JLARC review of foster care, there was a corrective action planning process that was put in place, but it was only for foster care. So as the state and as the commissioner of our department goes, there is no specific authority that the commissioner has to direct local departments of social services to step in whenever they are not performing and be able to put services in place to make sure that children and families are being able to be cared for within those jurisdictions. So what this does is this actually sets that process for the entire department. It builds off of what we did within foster care and expands it to the entire local department. This also lines up very well whenever I talk with you about SNAP. Our error rate for SNAP, which I will get into here in just a couple of minutes, is 11.5%. And so that is going to impact us financially as we look at trying to reduce that error rate, and being able to set standards and ensure that that's consistently applied across the state will help in child welfare and within that SNAP piece that we are looking at. So you will see the investment that is in the budget in order to create that system of oversight and be able to set up that corrective action planning process. The last piece of this is investing in our local departments of social services staff. By code, family service specialists are required to have a 4-year degree in order to work in these positions. The starting salary for those individuals right now is $38,000. It is not marketable. We can't recruit individuals to be able to come into those positions, and when we do recruit staff, they immediately leave and go into other positions. You will see on here that whenever you look at other similar positions that do not require a degree, the behavioral health positions that we approved as part of Right Help right now during the last administration are starting at $63,600 without a degree, and $54,400 for the community health workers, also without a degree. So that has to be remedied. It has to be able to be addressed in order to do this. Any of this requires local workforce in order to be able to work with their families. So everything that we talk about, everything that we do is shoring up that local workforce to be able to support our children and families. Those are the four major things that have been highlighted this year to try to improve Virginia's performance within the child welfare system, and really focused on the safety side of this within Child Protective Services. With that, before I talk about the SNAP piece of it, I'm going to shift gears on you really hard. So if you have questions about this, probably now would be the time, and then I can shift over to the SNAP if you'd like for me to.
Let's see, we have any questions for you? Go ahead, yeah, go ahead. Delegate Hodges.
Thank you, Mr. Chairman. Thank you for joining us today. Excuse my voice. Looking at the number of deaths by region, how does that compare?
Yes, so Mr. Chair, Delegate Hodges, the eastern region, which would be Virginia Beach down through Tidewater and in that area, has always had the highest number of fatalities as you look at abuse and neglect fatalities. That has historically been that way, and it has always been by region, and it's a little higher within the males than it is females that go along with that area. But that is traditionally in the eastern region has been the highest death rates that we see throughout the state.
Real quick
Please,
follow-up.
go ahead, yeah.
And when you talk about inconsistencies and, like screen in and so forth, can you explain that a little bit, what those inconsistencies might be?
Sure. So as you look at it, there are four criteria. When a call comes in and somebody says, hey, I'm concerned about this child from that end of it, is by code, we have four different criteria you have to look at to determine if it's considered a valid complaint. There is the child under the age of 18? Is there a definition of abuse and neglect? And so does that, whatever they're calling about, does that actually meet our code definition for abuse and neglect? Was that abuse and neglect perpetrated by a caregiver? So somebody that was actually in a responsible role, because that's important when you get into school systems, daycares, those sort of things. And then the last one is, do you have jurisdiction? So is the jurisdiction for them? So those are the four criteria that are laid out in code. We screen that case using a tool called a structured decision-making tool. So we provide one tool across the state. Everybody uses the same definitions. Everybody uses the same tools. And then they screen those calls that come in according to the code and according to that tool that we use. And then based on that decision, then they respond to those cases either in 24 hours, 48 hours, or 5 working days, depending on how it is screened in. Yes, sir.
Carla, thank you. I think everyone on this panel agrees that those are the toughest to look at slides I've seen, I don't know, ever. That's just really tough to process. I know we have to know the facts, so I appreciate you bringing those forward.
Yes, sir.
So not to in any way question how important those are, but I have been asked before on just the initial screenings and the referrals. How do you account for, like, if it's one child, but there are, say, multiple family members or caregivers calling in about that child? Do those count in that total? So what I'm getting to, does that skew the numbers?
Yes, sir, Mr. Chair, is all of those calls that come in is if you get what's called a duplicate report.
Duplicate, yeah.
Which means you've already received the call, somebody else calls in about it. It is absolutely part of that. It is part of that total from the end of it. So as we met with local departments and talked about these numbers and took a look at them, they brought up two pieces that go along with that. One of them is the percentage of anonymous complaints. Virginia allows anonymous complaints. So you don't have to identify yourself whenever you call in. You can say, I have a concern from that end of it. So they want us to take a deeper look at those calls. And the second one is the number of duplicate referrals. So is this the same call? Is this the same information? That sort of thing along those lines. So part of the bill that is making its way through will have us do a deeper study into what does that look like, how is that driving our numbers, how is that driving the inconsistencies. What I will tell you is, as you look at the numbers for the last fiscal year, and I'll just go across the last fiscal year, across the Commonwealth, same anonymous complaint, same duplicate referrals. I have localities that screen in 80% of all calls that come in. I have localities that screen out 80%. Same duplicate referrals, same anonymous complaint structure from that end of it. It's the inconsistency across those jurisdictions for how they're applying the code and the policy that really caught the attention of the stakeholder group this summer.
No, that's an excellent point, and I do agree, because you see that chart, and you're like, how can it be that different for the states? That does make sense. And then, of course, where I started my comments, the duplicates aside, the fatality rates are just absolutely unacceptable. So I think we can just look at that number alone, there's a problem. But I do appreciate that the study will get into, I mean, just to be more precise on how things are reported, but I think you really nailed it when you said the consistency is really where.
Yes, Mr. Chair, that was what was, I want to emphasize what really came out in the stakeholder group was the inconsistency from jurisdiction to jurisdiction. And so what we were asked to do at the agency level was to address that inconsistency and try to put forward something that would help to bring that in so a family is not disparately treated depending on which local department they work with.
Okay. No, thank you so much. Any other questions on this part? Presentation. I think we're good.
Okay.
Thank you.
All right. So now I'm going to shift with you. This is just a summary slide of what I just went through with you. It's in there for you to be able to see. Now I'm going to talk with you about SNAP. So completely changing your direction, but this is related to the One Big Beautiful Bill Act, H.R. 1, however you hear it referred to. Effective July 4th of this year, with the passage of H.R. 1, it significantly changes how we administer SNAP and Medicaid across the Commonwealth of Virginia. I'm going to talk about SNAP. Mr. Lenardi will be able to cover you the Medicaid side of it, and we'll talk more about that piece of it. What is in front of you is two major shifts that have occurred because of that. The first one being is that the federal government has always shared the administrative costs for the SNAP program in Virginia at 50-50. Effective October 1st of 26, so the first year of your biennial budget, that shifts to 25% federal, 75% state. That is a shift of roughly $94 million that the Commonwealth has no control over. It literally just shifts that money to the state and says, if you want to keep doing SNAP, you have to come up with this additional amount of money. It is primarily in our local departments of social services that do administration of the SNAP program. So when you look at where does almost all of that money go, it goes into the local departments to determine the eligibility for the 450,000 Virginia families that get that assistance. So it's about 450,000 cases, roughly about 850,000 Virginians that are on the SNAP program. As you look through that, not only did it shift the administrative structure from 50-50 to 25-75, it said that effective October 1st of 27, if you have a SNAP error rate, a payment error rate above 6%, you now have to pay a matching proportion depending on what your error rate is. On the screen is your structure that was established within H.R. 1. If you have an error rate under 6%, you have no match. If you have an error rate between 6 and right under 8%, you have a 5% match. Between 8 and 10%, you have a 10% match. And above 10%, you have a 15% match. Virginia's current error rate is 11.5%. So just based on those numbers, it will cost Virginia $270 million a year on top of the $94 million a year to continue administering the SNAP program from that end of it. So states were given the ability to reduce their error rate, starting with either federal fiscal year 25 which we were in the 10th month of that when HR 1 was passed, or we can focus on federal fiscal year 26 to try to reduce that error rate. So of course, we are focusing on federal fiscal year 26 to try to get that error rate down. Unfortunately, I will not get federal fiscal year error rate until June 30th of next year. That's the way the process works. So it ends September 30th of 26. The federal government releases that rate to me by June 30th of the following year. This year, I got it on June 30th. So just to give you a sense of, I will not be able to give you a clarification on what that error rate actually is until June 30th of 27. That's a big budget driver for all of us. Staff and I have talked about this extensively. Just knowing that shift and what it looks like, we do have some control over this. So this is why we need to focus on getting that error rate down and being able to drive that error rate down, because if we get this under 10%, we just saved $90 million of what the Commonwealth may have to spend. Previous governor told me it was my responsibility to get it under 6%. So that has been my direction from the previous governor. The new governor has said this is our number one focus, so we continue to focus on driving this error rate down. Just know it's going to be a bumpy road for us because of the way that those error rates are calculated when I get the numbers. Now, this is a timeline. I'm not going to spend a ton of time with you on it this afternoon. It's really just what I shared with you of when things go into effect. It's a great referral tool to go back and look at how do these things actually go when you're trying to figure out in your planning meetings of how this would function, but this is just how it goes. Okay, so what is included in the budget in order to try to address this? The first one is there is funding in the governor's outgoing budget that would increase the state share of SNAP administrative cost for the local administrative portion only. So I just want to reiterate that. And staff and I have talked a lot about this. This doesn't cover the entirety of that $94 million that we looked at. It only covers the local administrative, what is called 8515 portion of this. So I've got a slide at the end of this that'll tell you exactly what does that mean. But that's included in the budget that you have what's left for you to work with. There are 14 additional positions that are included in there to help monitor those cases to try to make sure they're right before they get into the pool that would lead to our error rate case. So that investment is there. And then trying to get our SNAP QC reviewer staff salaries up to where we can actually fill our QC reviewers. They're about 30% lower than other staff within the agency, so we have a trouble actually filling those positions, which may impact our error rate. That is what is included in the budget, not what is needed in order to address that error rate. So I'm going to leave you with this piece of it. For the SNAP administration piece of it, in order to keep us hold of where we were at before you do the 50-50 down to 25-75, you need an additional $27.3 million in the first year and $36.4 million in the second year in order to keep it at, just shift it from 50-50 to 25-75. This doesn't talk about error rate at all. The second piece of it is there's no money in the budget to account for the error rate. So if we get into October 1st of 27 and we are not under a 6% error rate, then there is no money that is in there in order to potentially calculate for that piece of it. So it's a big hole that is there. The printing and mailing contract, which is a piece of this, is that we are required to send out federal notices that come along with this. Is money was not included for the printing and mailing contract to actually mail the required notices in the outgoing budget. So these are the numbers that were short within the caboose budget that needed to be and in the ongoing budget. There is no money in there for SNAP technology. So VACMS replacement, which you just heard, House Bill 66, which will start the path towards replacing the larger system. This is investing in technology that will help drive that error rate down. There are technologies that other states have invested in that don't require a person to actually do the work. They can set within your system and actually control for some of those rates, but it needs about a $15 million investment across the biennium for us to be able to purchase those and put those in place. And then the income verification process, which comes into our Equifax contract that has been a runaway train over the last several years that we have talked extensively about in previous years, of trying to move to a different platform and be able to do enhancements that get into the gig economy, 1099s, those sort of things that are still done by hand that drive a lot of the errors that we see from the end of it. So when you look at what can we do, the investments in order to not pay $270 million a year, is there investments that need to be made, but those investments are not included in the budget that you have to work from that end of it. So with that, I know that's a lovely note to leave you on as the finance side of this world, but this is the reality of what HR 1 means for SNAP, and then what we are looking at with how we are able to administer that across the Commonwealth.
Okay. Carl, thank you again. That's super helpful. And I'll just make sure I get this right. You were saying on the governor's introduced budget, I know it doesn't show, it definitely has a slur. Does it show 6%? Is that the error rate's assuming, or is it assuming no error rate?
It is assuming no error. Mr. Chair, it's assuming no error
Okay.
rate.
I think staff had told me that before, and I just want to make sure I heard it right. Okay.
Yep, so that was
Okay.
Whenever I sat in the
Making it up,
office with the
okay.
governor, he told me my job is to get it under 6%, and we will not have an error rate that's above 6% from that end of it. And so that's what you see reflected in the governor's budget. And as I've talked with staff, they asked me, is that a reality? Well, we're at 11.5%. We've not been under 9.8% in the last decade from that end of it. So our ability to actually get under 6% is something that we have to seriously consider as we look going forward.
Okay, thank you. Question from Delegate Tran.
Thank you so much, Mr. Chair. I believe, sir, that there's some kind of delay in error rate reporting from the federal government that could would impact our understanding of where we are in this process. Can you help explain how those timelines match up and what that means for us in terms of reducing our error rate and when we would know that it is reduced?
Yes, so Mr. Chair, Delegate Tran, the way that error rate process functions is from the time that the federal government sends us the case that is pulled. So we have to send the federal government our entire caseload, and then they tell us which cases to go and look at through the quality control process. So we don't pick them, it literally comes back from the federal government. There's a process that takes approximately up to 143 days. So if you picked a case on October 1, you have 143 days through that process to actually finish it, for the individual to respond to and everything before you actually close out the month of October. So let's just throw in that 5-month time frame. So if you have October come in, the earliest I would get any data for October would be March to see what did we actually find, what did we actually see, and be able to do it. And that would only be the 1-month sample. As you get through the entire year of October 1 to September 30, because we're talking federal fiscal year, is that the federal government doesn't actually report our error rate until June 30th of the following year. So when the year ends on September 30th, they have 9 months after that ends. Now, remember, another 4 months of that is the timeline to finish the cases from the last month of the pull. But then they don't actually send us our official rate until by June 30th of the following year. And we have to account for that to start on October 1, whenever I will not actually get that error rate until June 30th. And I know that's completely confusing, and I've tried to think of a better way to explain it, but there's not really a better way to explain it because there's a 5-month delay from the month that you get the pull till we actually see what that month is. And then there are specific federal regulations that do not allow the QC team to actually tell the programmatic side of what they found in their reviews. And so we have asked for a federal waiver to allow us to work more closely between QC and the program because of the significant impact from that end of it. And so far that has not been approved from that end of it. And so we will continue to advocate to be able to do those so that we could get more real-time data. Because right now, the last month that I have of data is September of last year, and our error rate was still 11.5% September of last year. So it had not changed any, so I don't have anything more accurate right now than September of last year.
Delegate Tran.
And follow up, Mr. Chair. So does that mean that when the deadline is for us to have our error rate reduced, where we need to, where the penalty kicks in, I guess is what I'm saying. So when that deadline happens, we're not going to have updated data to show if we've made any movement at all by that point because of this time lag?
Mr. Chair and Delegate Tran, I will have that on September 30th of 2027.
Okay.
And this kicks in on October 1st of 2027. So everything that we're doing to try to reduce it, I will not know if we were effective. That is way too close, and it really impacts your planning processes because I can't get you anything more accurate until then.
Yeah. Thank you. Susan's got a question for you.
Could you address the $15 million technology supporting payment accuracy? If in fiscal year 2027, is it accurate to say that you would have to come back with the recommendations on what fixes are needed, and then if the General Assembly gave you funding at that point, you could move towards those technological solutions? That seems like that would take another period of time in order to get those actually implemented. Am I correct?
Yeah, Mr. Chair and staff, any contract that goes above $3 million requires us to procure it from that end of it. So if we can do something under $3 million and purchase it off of VITA's CAI contract, then we have the ability to be able to purchase technology and be able to get it in under that piece of it. So if you look at the $15 million investment, if it's a series of different investments, we do not have to go through the full procurement process, and it would not have the delay that you're talking about from that end of it. If we have to issue an RFP, in my career, I don't think we've got a technology RFP out quicker than 2 years. So I would love to give you but in all the years I've been doing this, I don't believe we've ever had an RFP for technology that moved quicker than 24 months. So then you're actually not looking to needing those sort of investments until the next biennial budget instead of this budget. So there's a couple of different things that come along with that. To dig you a little deeper down in that, we just did an RFI process that had 75 responses from vendors to what sort of investments could be made to drive this down. And then, so we've been going through those 75 responses in order to try to get those down and figure out what would be the appropriate technologies. And we just did 2 demos over the last couple of weeks to further spell out what those potential investments may look like. So I can actually give you some more detailed information probably in the next couple of weeks of what those actual investments may look like.
All right, Carl, next time you come back, you have it all figured out because you have data, right? I'm joking.
I would love to be able to tell you that, Mr. Chair.
No, I'm so sorry. Well, I think you see the puzzled faces up here because of that really is a conundrum. But you did a great job of getting us up to speed, and we really appreciate that on a Friday afternoon. So thank you so much for joining us.
Yes, sir. Appreciate you as always.
Yeah,
so thank you.
Good. And then we'll pivot right to Jeff Lenardi, who's going to also update us. We'll switch up some slides here. And we know Jeff's got it all figured out. I mean,
The diehards have stayed for this very uplifting briefing
That's
this
all right.
afternoon. Put it that way. Thank you.
thank you. Jeff, thank you so much. Again, you're great to come back. Appreciate it.
Thank you, Mr. Chairman. Members of the subcommittee, it's good to see you again as my delegate. So, I know it's been a long day, long week, so I'll try to be as concise as I can. I'll give a couple overarching programmatic updates, just sort of where we are and focusing into the next year. I have a bunch of slides on pretty much everything in the introduced budget. I will not go through them all in painstaking detail. Susan asked me to focus on 3 particular items, so I've got a little bit of breakout on those, but just stop me anytime you need to. Although if any of the questions are really hard, Steve will answer them in March. Again, I'll just give a quick Medicaid overview, talk about some agency-wide updates, and then dive into the budget. I always like this slide. We talk about at its core, we just have to make sure that we provide high-quality coverage and services to our members. We sort of boil this down internally to 3 things, and I just think it's important to start any Medicaid conversation with these 3 because it's at its core of what we do. Medicaid is complicated, it is expensive, but at its core, we need to make sure that eligible Virginians get enrolled in Medicaid. We then need to make sure they can get the services they need, and then we need to pay providers accurately and on time for those services. It's at its core, it's not that complicated, but as we'll talk over the next few minutes, implementing it is a little more complicated than that. This is just a snapshot of where we are in Medicaid. Our enrollment is shrinking as was expected in what we call sort of the post-unwinding world. We peaked at about 2.2 million Virginians, which was about 25% of the state population at that time. We're down to about 1.8 million now that we've completed the unwinding process. We cover a full suite of medical, dental, behavioral health, long-term care services for those who are eligible. Couple that I'll highlight. Medicaid covers a disproportionate number of births in Virginia. That's pretty typical across the country. About 1 in 3 babies born in Virginia is paid for by Medicaid. And then 1 in 3 Medicaid members has a behavioral health diagnosis. We're going to talk about some key behavioral health services and some changes being proposed. And I think the reason I highlight that is there's a really strong belief that the core services we provide are critical. People do need them, but we also must protect them from abuse so that the funds that you all appropriate to us get to the people who need them. I do like to include this slide because it just in any time I talk, because it is a little unique. You know that Medicaid is a shared program between the federal government and the states, and the way we are set up in Virginia, and most states are set up this way, we need your permission and funding and authority to do anything. We also need the federal government's permission. And so when we talk about policy changes, we have to make sure that we can align those 2 things so that we can implement them. I talked about that $1.8 million number. They are broken out across a number of different types of individuals, and they need a broad variety of different types of services. The other thing that matters for this subcommittee in particular is that the federal government pays a different portion of our costs for each of these buckets. So over there on the left, what we call base Medicaid, it's a lot of our kids, some of our adults, those with disabilities, the elderly, pregnant women. The federal government pays about half of those costs. There's a smaller number of kids whose families have slightly higher incomes in that middle green bucket, as well as some pregnant women with slightly higher incomes. The federal government pays about 2/3 of the cost of that green group. And then over there on the right, that's what we call Medicaid expansion. That is the vast majority of our adults. Some of them are parents, some of them are not parents. The federal government pays 90% of our cost for that. And then through the hospital assessment, our private acute care hospitals pay the state share, which is 10% of the cost for those individuals. There are some population dynamics going on in our Medicaid program. I'll talk a little bit more about them when we get to the forecast and the budget component of this. But writ large, as we come out of unwinding, what we have is our disenrollment numbers, as we go from 2.2 million to 1.8, the majority of those who are now no longer eligible for Medicaid are in the cheaper categories. So both in terms of how much they cost on average, so low-income children, they're our cheapest, adults, next cheapest, but also in terms of the federal share, the federal government picks up more of those costs. So we're losing those that the state bears a lower cost, and we're keeping those and continuing to grow as we normally do in those with the highest cost. So those are our aged, blind, disabled, particularly those that need long-term care in either nursing facilities or in the community. And again, the state covers half of their costs versus, a third to 10%. So that's a population dynamic that is not unexpected, frankly, coming out of unwinding, but is a big driver of some of the annual year-over-year spending growth that we're seeing. Just to snapshot our current priorities, there is a lot going on in Medicaid. I think DMAS and DSS are sort of walking arm in arm down this road of implementing a lot of H.R. 1 changes with some really tight timelines, some potential significant financial impacts, with a lot of operational implications that we're trying to sort out together. And so number one is always for us, our workforce. We've got to keep sort of a stable, happy workforce that does all the work. And so there are some key recruitments we're handling right now. We're interviewing and recruiting for a chief financial officer. That's going to be a critical role for us. Also recruiting for the staff for the Rural Health Transformation Program. I know there's been some discussion, and Secretary Figueroa briefed you all on that a couple of weeks ago. But workforce is really critical for us so that we can execute on what we need to do. When we say H.R. 1, there's a lot in there for Medicaid. We gave a fuller briefing to the HHS committee a few weeks ago. The ones that I think getting talked about a lot and that I'll highlight in the budget because we have administrative cost needs are those to implement work requirements in Medicaid for the first time, as well as to renew eligibility every 6 months for Medicaid expansion members. Currently, we renew them every year, so it's a doubling of that workload. Number three is implementing cost containment strategies that are recognized in the introduced budget. Most of the stuff that I'll highlight today, those are policy changes that you all need to review, approve before we implement. But there are some changes that are made administratively. I'll talk about some of those key ones in the particularly in the behavioral health area, where no new authority was needed. These were really, important programmatic changes that needed to be done to ensure cost-efficient use of our resources. So those, that funding has been taken out of the budget, and we are working really, really diligently to make sure we execute on those to meet our financial obligations. Behavioral health redesign, that's been ongoing for the last couple of years. In the introduced budget, there's a 6-month delay. There's been a lot of conversation around what the appropriate timeline is for that. We anticipate further conversation as session continues. Single PBM is one of the issues that I've been asked to highlight, so I'll just have a couple of slides that walk through the timeline and the funding needs and then expected future savings based on the study that was conducted this past year. And then this one doesn't maybe get as much airplay, but we are at the very tail end of, frankly, a very end-of-life IT system that is our core claims payment system. So every claim and every dollar that gets paid out of DMAS runs through this system. It has been end of life for far too long. And so it is being replaced. You all appropriated that funding a couple of years ago, and that is going to be a significant operational lift for us over the next 2.5 years or so that just is going to impact all the other priorities that we have to do. All right, in terms of the budget, I'm going to start with the forecast. I won't spend too much time on it. You guys have heard about that already. And then I'm going to talk about those 3 highlighted items that I wanted to provide a little more detail on. And then I will quickly go through some of the other flags. But again, I'm happy to talk about anything that's in here if you have questions. Okay, so the forecast was significant. There's no two ways around about it for this biennium. A big part of that is every other year we do what it's sort of inside baseball we call a need year. It's the start of a biennium. The assumption from a budgetary perspective is flat funding, and so that's not a reality in Medicaid or really any other program. And so there's always a significant need when you total it up over the biennium. But the growth year over year in this biennium is projected to be in the 7 to 8% range. That is much higher than I think anyone would like. There's a lot of reasons for that. We talked about those population dynamics, number one. Number two, those who are left in the program are continuing to utilize more services and more expensive services. Again, that's not something unexpected, but I think the magnitude of it is what is surprising. And then, as always, there's the full implementation cost of investments that the state has made. So out of the full $3+ billion, about 10%, a little less than 10%, $288 million of the general fund need over the biennium is the full implementation cost of the increase in the IDDD waiver slots that were appropriated a couple of years ago. And I think what the introduced budget tried to recognize is that obviously the state has a lot of needs, and so there are a significant amount of cost containment strategies included in that budget. And so I'll talk through them, and if you have any questions, I'm happy to take them. This is the starting point. So essentially the forecast is the starting point for the introduced budget, and then all the adjustments are based off of this. So I'm going to start with the single PBM. So the introduced budget, all it includes is a delay in the required implementation timeline and language that indicates that the implementation can't be conducted without administrative funding being appropriated. That administrative funding was not in the introduced budget. And so what I have here is last year at the direction of the General Assembly, DMAS hired a vendor to undertake a study of essentially the timeline and the likely fiscal implications of moving to a single PBM. That study was out on time at the beginning of December. And so what we've done here is really just consolidate the core takeaways to a snapshot of two slides, one on the best case timeline, and then one on the projected fiscal implications that the contractor analyzed. So this is the sort of the best case timeline. When we look at the earliest administrative funding could be provided is either some in the caboose or in FY27. And so when that funding is, when we have that funding, then we can undertake the activities required to not only get an RFP on the street, but then the year one funding, which I'll show on the next page, has both some of the initial costs to get the RFP on the street and make sure we do it in the right way, but then also the first 6 months of implementation. That's just sort of how the costs got broken down. Once the RFP hits the street, let's say if we hit that target January 2027, absent a bid protest, or litigation over the award of that contract, a 6-month timeline for both, offeror review, proposal review, and award and contracting is pretty standard. And then a year of implementation timeline. And again, one of the things to keep in mind here, when we talk PBM, or I apologize for the typo, the slide says PMB. When we talk PBM, I think, and this was something I've learned over the last 2.5 years, I think of PBM as primarily a middleman that is managing contracts. But one of the big implementation pieces for us is they manage an IT system that receives and processes and pays pharmacy claims at point of sale. And so it's that IT implementation that takes the lion's share of that time from contract award to go live. This slide's a little detailed. There's actually quite a bit more detail in the report that can be broken out if you need it offline. We tried to consolidate it here as much as we can. And what I've categorized it as is best case means the lowest cost or the greatest savings to the state, because the contractor gave us a range. Worst case is the highest cost or least amount of savings to the state. And so what you have when you look at the report is there's a bunch of cost savings from eliminating our current contracts with our fee-for-service PBM, as well as the admin component of what we pay the MCOs that they then pay their PBM. So essentially, one of the biggest cost savings is we're going from essentially 6 PBMs to 1. So there's economies of scale there, and that's where the lion's share of the cost savings come in. The drivers of increased cost are primarily on the front end. So while we're doing that implementation, building the IT platform, making all the contract changes, building the operational processes to make sure the data gets where it needs to go, and so on and so forth, we have to pay some outside experts to support us with that, make sure we develop this contract, have the requirements that are going to be in the best interest of the state and accomplish the state's goals. We also then have to pay whoever is awarded the contract to start that implementation, to build the IT system, to connect it to our systems, to connect it to the MCO system so that they have the data for care management purposes, and we have to test all of those things. At the same time, we've got to keep operating. So we got to keep paying, pharmacies for the drugs that they dispense and for their time to dispense those drugs. And so we're essentially paying double during that implementation period. That happens with every major implementation. It's going to happen with that fiscal agent service implementation that we're about to roll out. And so that is that's the primary reason for the need for an upfront administrative cost investment to yield the savings on the back end, which as you see there, sort of year two is what you can consider sort of steady state with an estimated savings to the state of between $10 and $22 million. The last thing I want to highlight here is the line that's called rebates and utilization management, and maybe could have been titled a little better. What you see, the vast majority of the savings and the costs here are on the administrative side, what we're paying to administer the pharmacy benefit. However, that pales in comparison to the cost of our prescription drug benefit. We spend about $3 billion a year gross in prescription drugs, and we get about half of that back in rebates. And so we need to do this in a very thoughtful way to make sure that we don't move that number in the wrong direction, and that this is done in a cost-efficient way that, again, meets the goals that the state has. I know one of the primary goals from this is to secure, improved and sustainable reimbursement for a lot of our pharmacies. And so we've got to build the policies that make sure that happens. And so we want to do this thoughtfully. And so I think the time investment, if you think about it that way, is well spent to make sure that the design of this accomplishes the goal, because it's much more complicated than meets the eye. Any questions on that?
Susan's got a question.
And Jeff, just to make sure that I'm clear on this, the one-time implementation fees, that would include getting that RFP ready to go out, all that preparation, making sure that the provisions of that are robust and protect the state's interests, that kind of thing, right?
Exactly.
Thank you.
Jeff, you just covered this. I want to make sure I'm going to try real quickly to get this right. Under the rebates, so the current MCO rebate loss and then the future rebates and UM efficiencies, those things are, you're trying to do better with one than the other, but the loss is a loss. Is that right? Or there's I'm trying to understand the cost there.
Yeah, exactly. So when the MCO rebate loss, what that is under our current pharmacy benefit, we have what we call a Common Core formulary. And within that Common Core formulary, we have what we call closed classes. So a class of drugs is a set of drugs that treats a certain type of condition. And the MCOs must follow that to the letter. So they have to have the exact same thing on their preferred drug list with the way that they work with their providers as the state does in fee-for-service. We also have open classes, okay? And in those open classes, they can vary. So what happens is in a closed class, we do that because the state gets all of those rebates. So any of those drugs there, the MCO pays for the drug, but the rebate comes back to us. So we pay the MCO, they pay the pharmacy, but then the rebate comes back to DMAS. On the open classes, we still do get rebates depending on what we have negotiated, but because they're open and that gives the MCOs some wiggle room, they negotiate supplemental rebates, okay? So we get a piece of that, but they can also get a piece of that. And we take those extra MCO rebates out when we set the capitation rates. So the MCO doesn't get to keep that per se. When we set capitation rates, our actuary looks and nets that out. And so when we go to a single PBM that has a really tight single PDL, there won't be any of those sort of extra MCO supplemental rebates. So that's what we mean by loss. That is money that essentially is coming back to the state indirectly, albeit, that no longer will be coming back to the state. Now, offset from that is by having a much stricter single PDL, we'll get more direct rebates as a state. So that's why you get it going like this. A graphic would be helpful. It's very complicated.
Delegate Hodges.
Thank you, Mr. Chairman. It's good to see you, Jeff.
You too.
One thing when I looked at it, I'm looking at the cost savings that you have in here in some of these rows. Have you done anything and looked at the NADAC model? I know that's in the new legislation because the states that I've seen where it's been implemented has saved states money.
Yeah, it's a really good question. So we had a meeting just this afternoon with some patrons on the methodology directed in that model. So in fee for service currently, we use what's called a lesser than reimbursement model. NADAC being the anchor of that, and then if NADAC's not available, we use several other things. And then we have, and I apologize, and I'd have to call up Dr. Barabell, who's our chief medical officer. If you really want to get into the weeds, we do require some of that for the MCOs, but not all of it. So that is a key question in terms of one of those implementation decisions that you all were just talking about. What do we require from an ingredient cost methodology? Do we mirror the fee for service? And what will be the cost difference to the state of doing that? Because that's an implementation decision that could drive costs one way or the other. Yeah. Okay. I'm going to move on to crisis services. So there's several proposed changes, and you see the bottom line here. This is one of the line items in the introduced budget under the cost containment strategies. I'm going to take just a brief moment and step back because it's a pretty jarring shift here from the PBM discussion to this. The 988 system in our crisis system is working, and it is saving lives for people who need it. This is not an indictment of that system. But what we do need to do is mitigate frankly, some provider abuse that we have in that system. And I'll give you some statistics to underscore that, why we think some of this is so important. There's sort of two buckets of changes that sum up to those costs in the introduced budget. The one on the left has to do with a service called Mobile Crisis. So this is the dispatch that gets sent out when somebody calls 988. Currently, those providers can bill for up to 8 hours of services after dispatch. After several years, scaling them back to 4, we think could still meet the need while obviously provide some cost containment. I think the major component, though, and this is where I mentioned those cost containment strategies that are already in flight, the major component of this was a substantial ratcheting down of the provider network in the Central Virginia region. So I'm gonna give you a couple statistics just to underscore this. So for mobile crisis response, when you look at it by region for the most recently completed fiscal year in FY25, in Northern Virginia, we spent about $2.3 million, and that served 1,400 Medicaid members who called 988, needed it, received a mobile crisis service, and were then transitioned to the next stabilizing service. In the Central Virginia region, we spent $144.6 million to serve almost 13,000 Medicaid members. Okay, so there's a lot that needs to be done to clean that up. It's an unacceptable level of abuse, to be perfectly honest with you. We're thankful. Richmond Behavioral Health Authority is the central hub for that system in Central Virginia. They did an RFP in the fall where they drastically limited the number of providers who they will dispatch to. And that accounts for a pretty significant majority of the savings that are assumed here in this budget.
I'm sorry, Jeff, to interrupt you. So that just seems like a huge number. So, I mean, it is just people taking advantage of providers taking advantage of the system that's driving that up. And you can document that? I mean, you can see
We are happy to talk extensively offline, but there's a lot of work, not just with RBHA, but between us, DBHDS, the Secretary's Office, and the OAG and the Medicaid Fraud Control Unit to not just narrow who can bill, but also to take action against the bad providers.
Okay. Thank you. That's good.
Okay. So community stabilization, this is a service. This is what we call a homegrown service. This is not sort of a widely available evidence-based practice that's across the country. This is something we sort of developed as a bridge. What it was intended for was if someone gets a mobile crisis call and the evidence-based or the robust service that they need is not imminently available, say they need intensive outpatient or partial hospitalization. Community stabilization was intended sort of the way it was described to me, and again, I'm not a behavioral health technician or a provider, but I do have one here. If you have additional questions, sort of a check-in service to make sure that individual stays safe, stays stable until they can get into the services that they need. Again, this is one that just is being overutilized. I'll use intentionally pared down language on this one. We're seeing, often build up to 30 hours per week for 2 to 3 weeks, much more than sort of the check-ins, the check-in nature of the service that was intended. The introduced budget eliminates the service entirely. And so the mobile crisis providers would need the link to a different service. We certainly have had some conversations with staff and others about are there middle grounds here to maybe rein in the utilization, but maintain the service to some level. And so we'll continue to provide whatever information you and your staff need as you contemplate that. The next big one, and this is really a national trend that's driving Medicaid costs, and I think driving costs for a lot of payers, not just Medicaid, is the use of applied behavioral analysis. And so this is a service, evidence-based, most commonly used. You see here, 88% of Medicaid users of ABA have an autism diagnosis, but there are scenarios we see where it's either being overutilized or not being provided in a clinically appropriate way. So one of the items in the introduced budget would be to pare down eligibility to those with an autism diagnosis. Again, that would impact 12% of individuals currently utilizing the service. What I will flag is under Medicaid rules, there's a policy called EPSDT, Early Periodic Screening, Diagnosis, and Treatment. The way that functions is it's sort of a secondary review in addition to whatever authorization criteria any service has. And so for children that desire or need or think they need ABA, and don't have an autism diagnosis, they would have that pathway. They would have to go through that second level of review. They're not always approved, but there would be that sort of, I'll call it a safety valve. The second one would be to impose a cap of 20 hours per week per recipient. Right now, we do require extra documentation for a 20-hour per week request for authorization. About 8% of children currently using it get more than 20 hours per week. This change would essentially make that they could only get 20 hours per week if it was approved under that EPSDT secondary review criteria. I will also say there are administrative changes we are taking to review billing, making sure that is appropriate. We're auditing to make sure that only appropriately licensed staff are delegating the service to those who are allowed to provide it and have that level of, licensing that they're allowed to provide it. And so all of those changes that are in flight are also assumed in the savings in the introduced budget. All right, that was the three. I will go through the rest of these fairly quickly. The two I'll highlight here, the Rural Health Transformation Program. As you heard a couple of weeks ago, the Secretary is taking a strong leadership role in this, and we're very grateful for that. We are supporting that as sort of the arms and legs, the administrative arms of that to work with CMS, make sure the money can flow, make sure we get requests for applications on the street and can implement that as effectively as possible. We talked about the single PBM process and what's needed to implement that. I'll spend a minute here on this slide, the very bottom. That is the budget request, or what's in the introduced budget, to implement those federal work and community engagement requirements, as well as moving to every 6-month eligibility renewals for the Medicaid expansion group. What this budget request represents is really baseline compliance. So it's core staff core systems, core processes to meet the federal requirement by this fall, which is when we need to start sending and communicating to our Medicaid expansion members who are going to be subject to these work requirements. What's not in here, and I know there's a lot of discussion about, and rightfully so, is funding for workforce supports, education supports, and the case management for individuals who are not exempt, who are not already in compliance, so that we can support them in bettering themselves and also making sure that they get the support they need to maintain their Medicaid eligibility. As you'll see, it's all non-general fund, given that this program is specific to Medicaid expansion. And so the federal government's paying 90% of those costs, and then the hospital assessment, the other 10. On this slide, there are some substantive policy issues here. I can go into them if you want. I'll flag the one with a dollar impact there at the top, because this is also one that I know you guys are wrestling hard with. These are rate increases for some of the DD waiver services that were included in the permanent injunction with the judge last summer, I guess it was. And so the permanent injunction gives the state the biennium to make meaningful progress towards increasing rates for DD waiver services that are included in that injunction. This is for 7 of the 11 services that were included. The other ones that were not included primarily are skilled nursing in the home as well as personal care. What you'll hear, the reason personal care is really the tougher nut to crack, because if we increase rates for personal care across the board, it's going to cost about $1 billion a year, and 85% of that cost will be not in the DD waivers. It'll be in our CCC Plus waiver, which the vast majority of personal care users are in. So that's one we'll be having more discussions about. On the nursing side, the spend is lower, and the majority of users of that are in the DD waiver. And that's also where we have more of a provider issue in terms of getting the DD waiver recipients those services. So again, we'll provide offline and to staff the data needed as you consider that, because I know it's a key discussion point as we continue to try to work collaboratively with DOJ and the federal judge on the permanent injunction. Okay, on this slide, I'm going to focus on the very bottom because this is an area of not great news. So the introduced budget estimated some savings with sort of what I'll call imperfect information. So we were expecting, and we got, our GLP-1 drugs were up for our Pharmacy and Therapeutics Committee to consider. And what that means is the manufacturers submit their bids for their rebates and their conditions on those rebate bids. The good news is the actual rebate amount on a per prescription basis came in where we expected. The bad news is the conditions on that we had to meet to get that rebate were much more extensive than we anticipated. And it wasn't just on the GLP-1s for weight loss or the injectables for weight loss. It included the oral indications for their GLP-1s, which are not FDA approved yet, but which is expected this spring. And it was what is called a portfolio proposal, which essentially the manufacturer says, you'll get this rebate on this drug, but you have to accept all these other ones into your preferred drug list. The P&T committee met just last week. What I will say is there's a much more detailed discussion to be had here. The P&T committee actually couldn't make the changes, even if we wanted to accept those proposals, because the state budget currently sets the threshold for the clinical criteria to access those drugs. But there's a broader discussion that needs to be had. We could bring it back up. We could put it back on an agenda in one of the coming quarters. But given the requirements, essentially the portfolio deal and the requirement to include the oral indications, I think it's very unlikely that the savings would materialize, because utilization would be higher than we had estimated back in the fall.
So, and then how does that work? Because I know I have the budget amendment related to the expansion there, speaking of my interest. No. So how does that square up in terms of the who's getting it, the range, the BMI range and all of that?
Well, it's a good question.
Okay.
So I guess the technical answer is DMAS is still operating on the budget language that assumes the governor's veto from last year. That was the direction DMAS received. There were several contested vetoes, 2 of which were in the DMAS front, one on nursing home rates, one on this language. DMAS is still implementing the budget language as vetoed by the governor. Because we haven't been directed otherwise and because it hasn't been challenged in court. And so I understand that that's a contested situation, but I just want to be transparent with what we're currently implementing.
Susan, go ahead.
So just jog our memory a little bit, is that, we had language in before the language changed last year. So coming in before we passed Chapter 725 last year, we had criteria in there for the weight loss drugs. I want to say it was 37% BMI with other conditions and 40%.
That sounds right. It's either 37, 40, or 35 and 40.
Is that what we're still operating on right now?
That is what we're operating on.
Okay, all right.
And I believe the General Assembly language from last year was the FDA approved indications. I think, is it 27 and 30, Greg?
I don't think it was that low.
It wasn't that low.
I thought it was more like, 30 and 35, or I don't.
It may have been. We'll go back.
Than
But
that,
yeah.
Mr.
And we can get you
Chairman.
the detail on what was in the proposal of what the manufacturers are requiring for the supplemental rebate.
I'm going to get to Delegate Tran, but just to finish that thought then. So if you were directed to do what was done or requested, how does that look going forward?
We need to go back, and I mean, we're doing it, to look at what is our utilization estimate now knowing the proposals. Because we don't get those supplemental rebates. And again, I'm going to give you very gross numbers. It's way more complicated. But essentially, the sticker price is about $1,000 a month. And when you net out all the rebates in the proposal, it comes down to about $240, $245 a month. So you're getting about a 75% rebate. But to do that, you got to use the clinical criteria they asked for, and you have to include all the other drugs that they want in the right spot on the PDL. And so there's just a fundamental equation that we're still doing the math on, which is we save X dollars on the cost of the GLP-1s, and that is going to be offset to some degree, if not all the way, by more Medicaid members being able to use those drugs. And so that's the math. Yep. But I don't have the answer to the equation yet for you.
All right, thank you. Delegate Tran.
Thank you, Mr. Chair. Along this topic around the weight loss drugs, are we tracking, for example, and I'm trying to think about how to phrase this, are we tracking better health outcomes for the individuals who are accessing this benefit so that we're not just looking at what the cost is, but any potential savings because it's affecting heart health and other, for example, other issues that we might also, instead of be caring for?
Yeah, it's a really good question. The total cost of care is sort of the $1 million question with a lot of these prescription drugs. And that's the goal, is to spend money here on the prescription drugs to save money over there and to save lives. So the short answer is yes, and we can look at that largely we look at it currently from an actuarial perspective because that's how we pay for the total cost of care is through our MCOs. There hasn't been enough in Virginia Medicaid, enough data that I can say definitively, because a lot of those are long-term. There's certainly plenty of studies out there, but it's an open question as to whether or not this is long-term a net cost saver.
Yeah, certainly what I based my amendment on was some of the numbers I saw. But again, those were national projections, but I think it'll play out truly here. But that gives me a couple of follow-ups there. Thank you for those questions. We interrupted you. What else you got for us?
No, that's totally fine. I'll just flag, these are the ABA and the Behavioral Health Crisis Services we flagged here on lines 3 and 4. This is another one I'm flagging bad news, I guess, today. So part of H.R. 1 is a requirement that states take a more proactive approach on cleaning up their enrollment when a member's enrolled in 2 different states at the same time. We are in the process of, we've always had a process to do this. There's a data system federally that sends us information quarterly. And we have a process where sort of the onus is on the state to assess where that person lives, and when we find that they definitively don't live in Virginia, we disenroll them. That takes a very long time, and it's very resource intensive. What the federal government is requiring is that we flip the script on that, and in an automated way, we identify that Jeff Lenardi, he's enrolled in Virginia, but he's also enrolled in North Carolina, that essentially a paper notice gets mailed to that person, and they get 10 days to respond and tell us to confirm, do you still live in Virginia or not? And obviously, if they respond that they live in Virginia, we keep them enrolled. If they respond they live elsewhere, we disenroll them. And if they don't respond, we disenroll them. That automation in our system is in the queue with the work requirement changes, with the every 6 month redetermination changes. And so the timing that's assumed here that we would start to yield these savings in FY26, we're not going to hit. And on that uplifting note, I'm happy to take other additional questions.
Well, I always say it's better to know than not to know, better to know now. So no, thank you, Jeff. I appreciate that. Delegate Tran's got another question for you.
Mr. Chair, I have two questions.
Two questions.
One on the presentation, I think it was on page 21, where you talked about the governor's introduced budget on the live-in caregivers and the EVV waiver. I had worked really hard to put that initial exemption in several years ago, and would love to hear kind of the thinking behind why we're taking that exemption out now.
Yeah, I'm trying to find it because it's not here on 21. I know which one you're talking about, though.
I'm sorry, I think it was maybe 19. Oh, okay. Sorry.
I get it. All right, so Delegate Tran, you're just going to have to excuse me. Make sure I orient myself to, because there was a lot in here. Yes, so most of our caregivers, let me make sure I get this right, a lot of our caregivers are live-ins, and EVV is a fairly standard accountability tool for clocking in and clocking out. And so, again, it's not a significant amount of savings, but from a program integrity perspective, that was why I was included in the introduced budget. I do know that's been a long discussed topic.
Thank you, Mr. Chair. My second question was, sir, when you came to the HHS committee at the beginning of session, I'd asked if you had a sense then of how many refugees, asylees, and other immigrants within the various visa programs that are no longer going to be eligible for Medicaid are in Virginia. How many folks are affected, and what the outreach strategy will be for those? I was wondering in the last couple of weeks if you've been able to gather that data.
Not in a reliable enough way that I'm ready to share it. We're farther along than we were 2 weeks ago, but not ready for prime time. And the reason is simply that there's the category, like it's easy for us to look in our system and say, oh, if it's everyone in this, we call them aid categories. If it's everyone in this aid category, fine. But the federal definitions in HR 1 don't align one-to-one with our aid category, so it's a little more painstaking to make sure that we're getting a reliable number.
Thank you.
Thank you. Jeff, as always, you're so knowledgeable on this, and there's a lot to know, and yes, we do ask you to bring us the news, and sometimes the news is not what we want to hear, but we need to hear it, so really appreciate you covering that for us. And if there are no other questions, we're just going to thank you again. Carl, thank you again for being, thank the whole team for being, this is great. With that, thanks everyone for sticking with us, and we are adjourned.
Thank you.